Thank you, Eleni. Thank you, Dr. Marina, for the outstanding lecture. Now, moving on to our fifth speaker for today's webinar, Professor Dimitrios Goulis, who is a full professor in reproductive endocrinology, serving at the first department of obstetrics and gynecology at the Medical School, Aristotle University of Thessaloniki, Greece. He is currently, or has been, among others, president of EMAS, the European Menopause and Andropause Society, President of the Hellenic Society of Andrology, Vice President of the Hellenic Society of Endocrinology, Treasurer of the International Society of Endocrinology, Secretary General of the European Academy of Andrology, Secretary General of EMAS, Training Center Director of the European Academy of Andrology, Director of the Master Science Program in Research Methodology in Medicine and Health Sciences, and Deputy Director for Master Program Science in Human Reproduction and Medical Research Methodology. He has published more than 420 full papers in peer-reviewed international journals. His main research interests include male reproductive endocrinology, female reproductive endocrinology, endocrine and metabolic complications of pregnancy, menopausal transition, andrology, and evidence-based medicine. And I would also like to add that Professor Goulis is also a mentor within the ESE clinical observership program since the very first launch of this clinical observership program. And many early career investigators had truly career-changing experiences thanks to his mentorship. Professor Goulis, the floor is yours.
Thank you very much, Christina, for this nice introduction. I'm so happy to be surrounded by young endocrinologists in ESE in this nice collaboration between the European Society of Endocrinology and European Menopause and Andropause Society. So congratulations to Christina and Eleni that represent these two societies and made this event possible. So we'll discuss about spermatogenesis induction. This is my conflict of interest. And I'd like to mention the famous English poet Rudyard Kipling that said that I had 6 honest serving men. They taught me all I knew, and their names are where, what, and when, why, how, and who. So let's do the same, put 5 questions, and try to answer them one by one. Spermatogenesis induction, what is it? When is it needed? What is the background physiology? How can it be achieved? And what else do we must know? Let's kick off. So testicular function has 2 parameters. One is the failure of the endocrine function, characterized by low serum testosterone, known as male hypogonadism. We have 2 lectures on it. And the other is the failure of the exocrine function, which poor semen quality, and this is male infertility. And the 3rd and 4th lectures of today's event has to do with this. Of course, if you have a failure on the endocrine function, eventually you will have a failure on spermatogenesis. The opposite is not true. So there is a close connection between hypogonadism and sperm failure. And as we already discussed with Alessandro and Walter earlier on, we have the hypergonadotrophic hypogonadism characterized by a failure at the testicular level. Klinefelter syndrome is the archetype, the prototype disease, but it's not the only one. There are other causes, congenital and acquired, as you can see on the slide. And we have the hypogonadotrophic hypogonadism, failure at the hypothalamus or the pituitary level. The Kalman syndrome is the prototype disease here, but once again, there are many congenitals and acquired causes of it. As already discussed with Alessandro Amodeo, there are more than 60, almost 60 genes that explain roughly 50% of the cases of congenital hypo. And not all of them has exactly the same clinical picture. Some of them are reversible, and this is because this is why genotype does matter in this disease. And then, as we discussed already with Walter Vena, Functional hypogonadism is characterized as its failure at both hypothalamic and pituitary level and is associated with advanced age and other comorbidities such as obesity, as we discussed with Walter. So on the classical causes of hypogonadism, we can add some functional one, and the same is true for the causes of hypo, we can add some functional ones as well. So how about spermatogenesis induction? It's obvious that there are not many things that we can do for hypergonadotrophic hypogonadism, rather a prevalent disease, but there is very few that we can do because the primary organ, the testis, is affected. On the other, it's a lot that we can do with cases of hypogonadotrophic hypogonadism, and the same is true for functional hypogonadism. Although this is characterized by advanced age, we have now many men that want to be fathers at an advanced age. So we can deal with this as well. Just to close this issue concerning hypergonadotrophic hypogonadism, the only thing that you can do in case of an azoospermia is a testicular sperm extraction through a multiple biopsy. And although there are already some medical intervention in the literature that you can do before ESE, none of them has proved its efficacy. So actually there is very few things that you can do in terms of hypo. Now, what is the background physiology of this effect? This is what we learn in the medical school. We have the hypothalamus that produces GnRH, and then pituitary, the two gonadotrophics produced by pituitary, LH and FSH, they act to the testis, and testis provides its two functions, the endocrine function, production of testosterone, and the exocrine function, production of sperm. So you need both testosterone and FSH in order to have sperm production. Of course, testosterone has its well-known negative feedback at a hypothalamic and pituitary level. But we need to learn a little bit more of physiology in order to be able to discuss spermatogenesis induction. So it's important to realize that we have other ways to increase production of testosterone by Leydig cell. It's not only the endogenous LH, but we can have human chorionic gonadotropin, HCG. We now have recombinant LH, and we have the human menopausal gonadotrophics that they have both an FSH and a weak LH action. So we can use this for production of testosterone by Leydig cells. Keep in mind that during the fetal life, it is the placenta that produces placental HCG, and this is another stimuli for Leydig cell to produce testosterone in the endometrial life. On the other hand, we have many medications that can use in parallel to endogenous FSH, and this is recombinant FSH or long-acting FSH that you can use once weekly, and as we already discussed, human menopausal gonadotrophics. Another important thing is that the Leydig cells do not produce only testosterone, but insulin-like factor 3, which is an important stimuli for testicular descent. And this is the reason that even in cases of hypogonadism, that the production of testosterone is very low, it's the insul 3 molecule that makes the testis to be rather than inguinal, rather than in intra-abdominal position. And of course, Sertoli cell not only nourishes spermatogenesis, but produce anti-Müllerian hormone and inhibin B. So consider this as markers of a healthy Sertoli cell. It's usually the immature Sertoli cell that produces anti-Müllerian hormone and the mature Sertoli cell that produce inhibin B. And of course, inhibin, as its name denotes, has a negative effect on the production of FSH, not LH. And this is the whole physiology that we must know in order to understand where we discuss now, which is spermatogenesis induction. So up to now, we have said that spermatogenesis induction can be applied in cases of hypo or functional hypogonadism, and we discuss the background physiology of how to do it. But how can be achieved in clinical practice? We can do it with two ways. One is to give what is actually missing, and this is GnRH, and usually we do this in a pulsatile way. Another way is to give the gonadotropins, and there are at least three ways to supply gonadotropins. One is monotherapy, and when we refer to monotherapy, we mean HCG only. The second is combination, so both FSH and HCG. And the third one is a sequential model. So you start with FSH alone for a couple of months, and then so a pre-treatment, let's say, and then you proceed into FSH and HCG in order to have the treatment there. Let's discuss them one by one. Pulsatile GnRH. This is the dose you can see on the slide, about 25 nanograms per kilogram, and you give it as a bolus through a pump every 2 hours. So every 2 hours you inject such a bolus. The titration, what you want to do is to adjust the dose of GnRH in order to reach mid-normal serum testosterone level. What are the benefits of this? It's the most physiological way to induce spermatogenesis. It's actually what's actually missing. On the other hand, there are some cons. It requires clinical expertise, and its availability is limited. You can use even an insulin pump if you do not have a dedicated GnRH pump, but of course insulin pumps are for insulin, not GnRH, so sometimes the software there, it's not supportive. Insulin pumps usually use them for a continuous basal rate rather than pulsatile that we need in GnRH. But of course, there is a way to give a GnRH. Now let's go to giving back gonadotropins, and we already discussed three different options. The first is HCG monotherapy. At about the dose you can see, from 500 to 1500 subcutaneous injection, 3 times weekly or every other day, whatever is more convenient for the patient. They have the same efficacy. And here your target is to adjust the dose of HCG based on trough levels. Trough means exactly before the next injection. So you measure testosterone and estradiol, and you try to have testosterone in the middle of the normal. You also may measure estradiol, because if you increase estradiol by a lot, you may have gynecomastia, which is the most common side effects of HCG monotherapy. It is good, it's effective, but not very effective. It's suboptimal for absent puberty, so testicular volume very small, less than 4 ml. In this case, you have to add FSH. So you can use different combinations. In your country, you may have very different combination of HCG, either as injection or more conveniently in the form of a pen. The second thing that you can do is to use combined gonadotropic therapy. That is HCG, about the same way you did for HCG monotherapy, and then to add in a combined way FSH, either a low dose 75 or a middle dose of 150 or a high dose of 300 international units, once again 3 times a week or every other day. Once again, the target here is for HCG to bring testosterone back to the middle normal. You can measure FSH. FSH is very low in hypo. So what you give is what you measure. So you want to have serum FSH levels of about 5 international units per liter. It is more effective, the combination, than HCG monotherapy. It has about the same effectiveness as the PAM, the pulsatile GnRH. So you need it in more severe cases. So this is the HCG, either in ampules, vials, or in pens, and the same is true for FSH, either in vials or in pens, which is more convenient. And the last thing, probably the most effective, is this sequential gonadotrophic therapy. So you start with the pretreatment, FSH only, 75 to 100 international units, rather low dose, 3 times a week for 2 to 4 months, usually for 3 months. And then, after 2 or 3 months of treatment, you proceed to the combined way, as we discussed earlier on. And it seems that although the data are sparse, this is the most effective thing. So pre-treatment with FSH only, and then you proceed to combination HCG and FSH. What else do we have to know? In females, in case of a hypo, the possibility of inducing folliculogenesis, ovulation induction, is almost 100%. This is, for various reasons, not true for the men. You are going to be effective in the majority of cases, but this would be only up to 75 or 80%, not 100% of the cases. Why is this happening? Well, let's discuss this. These are 5 periods in men's life. This is the fetal period, this is the mini puberty, the early puberty, the usual puberty, and the adult life. And this is testosterone. So, as you know, we have 3 peaks, one during the fetal life, one during the mini puberty, and one during the puberty and adult life. And I would consider this curve as normal. So it's the placental HCG, not the initiation of the axis of the fetus that produces the increase in testosterone during the fetal life. On the other hand, we have the first initiation of the fetal axis. So it's the fetus that produces LH and FSH, and this is the reason for main puberty. And of course, this is the reason during the normal puberty, the adult life, it's the pituitary of the adolescent that produce LH and FSH. So this is normal. This is the case, as discussed before by Alessandro, of prepubertal hypo. So everything is normal, the fetal period, the mini puberty, and from some reasons, I do not enter puberty. Let's say I develop a tumor there or any other things. But the 2 previous phases are there. This is the case of post-pubertal hypo. So for some reason, once again, you name it, many reasons, already discussed it, you have a problem there. But look what's happening in a case of congenital hypo. You still have the first increase of testosterone during the fetal period. And once again, this is because you have HCG by the placenta, but it's the only case that you miss the mini puberty. And it looks that this is detrimental for induction of spermatogenesis later on. So the absence of mini puberty may be one of the causes that we have not 100% success in inducing spermatogenesis in these men. So it's very important to recognize these men that have congenital hypo. These are some clinical characteristics that it's there in general population, and you can see their very high prevalence in boys with congenital hypo. So it seems that we have at least 4 well-recognized negative predictors for fertility in congenital hypo. And this is absence of spontaneous puberty, testicular volume less than 4 ml, cryptorchidism, especially bilateral, low serum inhibin B. Remember that this is a proxy of good functioning of Sertoli cells, And then if you have specific genotypes, such as the ANOS1 or the CAL1, it's the same gene. So these are negative predictors for induction of spermatogenesis, and I give you the best evidence for each one of them. So what we have discussed today, that we have 4 negative predictors of fertility treatment that can be identified through appropriate investigation. This is why genetic counseling is recommended for this male to see what will happen and of course what will pass in the next generation. 70 or 80% of the males, but not all, will develop sperm in the ejaculate with one of these ways we have discussed. We keep monotherapy with HCG only for, let's say, mild cases that we have a certain testicular volume, more than 6 ml, I would say, and we use sequential treatment for more severe cases, the most severe cases. Sometimes we need a lot of time, at least 1 year, sometimes up to 2 years, in order to reach maximal testicular volume and sperm count. And of course, sometimes it's possible to achieve pregnancy even with a very low sperm count. Imagine you start from azoospermia, from 0, so you go then. In order to put all of this in one slide, I took it from an excellent paper by Dyer, and I modified it a little. Remember the 4 negative predictors of fertility outcome, and have in mind the phenotype from severe cases, absent mini-puberty, up to partial cases as discussed by Alexandro. So keep the sequential treatment, FSH pre-treatment, and then HCG and FSH for the severe cases. For the intermediate cases, you can use other pulsatile GnRH if it's available on your center, or the combination, and keep monotherapy only for the mild cases of this. Still, we have a lot of questions, so we miss a good clinical guideline about what's happening in clinical practice, and we need an evidence-based guideline. We need direct comparisons between these 4 approaches I have described, and because these are rare cases, we need multi-center studies in order to see the impact of neonatal gonadotropin treatment on future fertility. Those with missed mini-puberty, we need longitudinal studies. The same is true for adolescents. And of course, we need data sharing in order to associate genotype with phenotype, and we need registries for this. The same is true for it's so important to have outcomes that really affect the patient. So not only sex steroid normalization or appearance of sperm on ejaculate, we need for outcomes that are patient reported. So I'd like to share this evidence with you. Christina already mentioned that in Thessaloniki, we have a center of clinical practice in reproductive endocrinology, so we'd be more than happy if you can join us in the nice city of Thessaloniki. Thank you very much.
Thank you, Professor Goulis, for the outstanding talk. I would like to ask Elena to introduce our last speaker for today's webinar, and then we will have the Q&A session.